I am Vijay Trehan. I am chairman of Cardiology, Maharaja Agrasen Group of Hospitals. Well, I've been using stents for more than 2 decades, nearly 3 decades now, and stents have done wonders. And there was a time when, if there is a vessel closure during an angioplasty, so that used to be kind of havoc. Patient had to be rushed to the surgical OTs. But ever since stents came, I think these sudden problems have almost vanished. We are able to handle all those problems in the cath lab itself. Then came problem related to the stents, and initial stents were just simple metals, and there used to be too much of tissue in growth. Almost 1 in 4, 1 in 5 of the stents used to get defunct after some time. That used to be largely because some tissue growth has taken place. So then came the concept that put some drug on it, and all those drugs were anti-cancer drugs. So they will prevent growth of the tissue through the mesh of the stent into the lumen, and that started to work like wonders. And first stent which came and proved was Cypher stent, and that kind of totally eliminated the slow ingrowth of tissue into the stents, and we were dreaming that everything is rosy. However, it was not very long that we all realized that there are problems related with even the so-called best stents like Cypher. Cypher was Cipher. Cipher means zero reobstruction, 0% reobstruction. So what the problem what we realized was that despite the fact these stents can nearly eliminate regrowth of tissue within the stents, these medicated stents, but they invite a new problem. That new problem was in the form of sudden clot formation within the stents. And then we started to see those Cypher stents. Patient received a stent now, and then 1 year, 2 year, 4 year, 10 years down the line, suddenly the patient gets a heart attack because you developed a clot within the stent. And also, if you want to prevent this clot, you have to keep them on blood thinners for a long period of time. That means you are inviting bleeding issue, because if you give them blood thinners and strong blood thinners for a long period of time, you invite bleeding. So we started to get patients with GI bleed from the urinary tract, bleeding into the brain, sometime remote after the stenting, 2 years, 3 years after the stenting, because 3 years down the line, this patient is still receiving antiplatelets, 2 antiplatelets, because you don't want a thrombus to form. So we started to solve the problem of acute occlusion by using stents. But then the problem of restenosis came, and to prevent restenosis, we started to use a drug. And the moment we started to use a drug in the form of drug-eluting stent, we started to buy problems in the form of either sudden occlusion with a clot or bleeding. Now with these issues going on, everybody thought we should use something when these issues are not there. So then came a concept that let the metal not be there. So that was the concept of so-called absorbable stents, and they came and they were used all over the globe. There were some issues related to it, but then because of the issues, those stents were withdrawn from the market. The idea was that if you don't leave a stent there, there is no cage of metal inside the artery. The artery is free to expand and free to constrict depending upon the demand. And like we say that if you see good things, you smile. If you don't see good things, you frown. So does the artery. And if the cage dissolves, this is what was thought, that if you put a absorbable stents, after some time the stent will go off, now the vessel will be free. So if the vessel is free, the vessel can smile, it can enlarge, or it can dilate, or it can constrict depending upon the need. Now the same thing can be done with the help of balloons, which can deliver drug to the vessel wall. And this is what is the concept of using drug-eluting balloons. But the first and the foremost thing for using drug-eluting balloons is you have to use the balloons in such a way so that you can produce excellent results with balloon itself. In fact, I say you should be able to produce stent-like result with a balloon. And if your stent-like result is there with the balloon, and then if you want to top it up, that area with a balloon which is carrying some drug and just finish the procedure, then this is the ideal situation. However, in large number of cases, your angioplasty skill may not be good enough. You may create visible dissections, and those visible dissections might, because nowadays when we are using stent, we are not in the habit of looking at vessels which are dissected, and we don't want to leave the vessels which are dissected. So it is better that if a vessel is dissected, should at least be flowing well, and if a vessel is dissected, in fact this will help delivery of the drug to the vessel wall. So now I feel that if you want to prevent thrombosis, if you want your vessel to smile and have a good vasomotion, if you don't want the full metal jacket, and especially if you are handling diabetic population where the vessels are small in size, they have a diffuse disease, so then in such situation it is better that you end up in an area which is well flowing and has drug which is delivered by a drug loading balloon and not a full metal jacket. I have been using this drug loading balloon for last nearly 18 years, and initially I had used balloons from Eurocor, and I had even conducted a trial on that. 100 cases we had done even check angiogram on 97 of those cases, and the results were very good. But now the drug loading balloon technology has improved in the last 15 years tremendously. Different players have come. Some people have even tried limuses, and they are difficult to put on the balloon and then deliver to the vessel wall. The Taxol varieties are easily put and easily delivered to the vessel wall, but there is still competition, and I think one has to understand that now there is something new, and that new is, don't leave a metal jacket there. You can just deliver drug through a balloon. And another important point which these drug loading balloons do is that they tend to be somewhat toxic to the vessel wall, and that toxic part tends to cause positive remodeling, something which used to produce aneurysms related to drug. Similar thing happens to the vessel wall. If you deliver drug there, then these vessels tend to be positively remodeled after some time, which a stent will not let it happen. And if it is happening in the stent, then this will lead to late incomplete malapposition, which is not desired. But if there is no stent and the vessel expands, it is always a good thing. If it doesn't expand to aneurysm, it just expands, it is much better to have a vessel which you left at 2.5, it become 2.75. I think it is much better to have a technology like this. So I will say that before you want to use it, try and understand what it is, and like I've been using it large number of cases because I am tuned to produce stent like results with the balloon, and I am confident that if there is some apparent dissection which is looking like a dissected vessel, but I know it's a good TIMI3 flow, these vessels will not close. However, if you are trying to use, your intention is to use a drug loading balloon and you dissect the vessel and you get into a kind of obstructed flow, certainly you will have to end up in a stent. In those situations, you will have to deliver double drug, means you have given a Taxol through a balloon, and then on the top of that, it's your choice. You want, nowadays Taxol related stents are usually out of the market, so you will have to use some of the limuses. But another situation where I use these drug loading balloons is LM bifurcation in stent restenosis, and I find to deliver a drug through a balloon and top it up with another stent which is a drug loading stent, so you have double drug in that area where you have aggressive restenosis. I've done few cases, and I'm quite convinced that in such situation who have recurrent instant restenosis in critical areas, you can use drug loading balloon followed by drug loading stent. So thank you very much.